Hello, my name is Dr. Roger Henderson, and I'm one of the co-hosts of the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, I'll be discussing a condition that we frequently see in both outpatient and inpatient settings, and that's Intertrigo. Now, although it may seem like a minor irritation at first glance, this can progress into a significant clinical problem, especially when secondary infections take hold. So let's walk through what Intertrigo is, why it happens, and how we approach it in practice. But let's start with the basics. Intertrigo refers to inflammation that develops in areas where skin surfaces rub together. So think of the axillae, the groin, abdominal folds, or beneath the breasts. And the very name gives this away. It's derived from the Latin. Inter means between, and terere means to rub. And these are warm, enclosed spaces, and the combination of friction, heat, and moisture can all create a perfect storm for skin breakdown. And because these skin folds trap sweat and limit ventilation, the skin there can become macerated or softened to the point where its barrier function is compromised. Now, once that barrier starts to erode, microorganisms take advantage, and Candida in particular thrives in these warm, moist regions. But bacteria and viruses can also step in. And it's this interplay of mechanical irritation and opportunistic infection that drives much of the clinical picture we see. Now, Intertrigo can occur across the lifespan, so we can see it as nappy rash in infants, and at the other end of the spectrum in elderly patients with limited mobility or incontinence. Environmental and systemic factors can also shape its prevalence, so hot, humid climates make it more common, and conditions like obesity or diabetes dramatically raise the risk. So in diabetes, for example, a higher skin pH in body folds makes those areas even more hospitable to microbes. And if we look at the pathophysiology even more closely, then flexural regions naturally maintain a higher surface temperature than other parts of the body. Add things like trapped perspiration and mechanical friction, and the stratum corneum becomes damaged. And once the skin barrier weakens, then resident bacteria and yeast, which are normally harmless, are then able to overgrow and turn a simple rash into an infectious process. Now, interestingly, if you were to biopsy Intertrigo, you would rarely find any distinctive histological features, and at most you might only notice mild spongiosis. And this reinforces the point that Intertrigo is primarily a clinical diagnosis. So, it's characterized primarily by erythematous patches, which are often symmetrical. And this erythema may then progress to more intense inflammation with erosions, fissures, exudation, crusting, and even maceration. And candidal Intertrigo may present as typical satellite macules, papules, or pustules. Toe web Intertrigo is common and may be mild and asymptomatic, but it also can present with intense erythema and desquamation, which is sometimes erosive, malodorous, and macerated. And patients also may have profuse or purulent discharge, and in severe cases may be unable to walk normally. Patients with very advanced gram-negative infections may also have green discoloration at the infection site. And patients with severe toe web Intertrigo who are overweight or who have diabetes are at a higher risk of developing cellulitis. Now, although Intertrigo is usually clinically obvious on examination, then certain situations may call for additional testing. And if you suspect bacterial infection, then a culture can guide therapy. For potential fungal involvement, a potassium hydroxide preparation from the active edge of the rash can be helpful, as it shows budding yeast or branching hyphae under a microscope. And a Wood's lamp examination can also help detect things like erythema or Pseudomonas. Now, if the rash is unusually persistent, atypical, or refractory, then a biopsy may help rule out look-alike diseases. And in recurrent cases, it's always wise to check blood glucose levels, since undiagnosed diabetes frequently plays a role here. When we look at managing Intertrigo, this involves tackling both the environment and any infection that's developed. And so that means reducing moisture and friction, improving airflow, and keeping the affected areas clean and dry. And patients often benefit from absorbent powders or drying solutions here. After sweating, then gentle washing and careful drying with a soft towel makes a noticeable difference, and some barrier preparations help protect the skin and reduce irritation. Now, if there's bacterial infection, then simple topical agents like mupirocin may be enough for mild cases, but more extensive infections may require systemic antibiotics such as flucloxacillin or erythromycin, depending on the suspected organisms. Now, when yeasts are involved, then topical antifungals such as clotrimazole, ketoconazole or nystatin are usually effective, whilst more resistant cases may require a short course of oral fluconazole. Anti-inflammatory therapies such as low-potency topical steroids can reduce discomfort, but these must always be used judiciously in these thin, sensitive areas of skin to avoid any atrophy. Now, in my experience, toe web infection can be stubbornly difficult to treat, and the skin must be allowed to breathe by the wearing of appropriate footwear and leaving the feet bare at home whenever possible. Dactocort cream twice a day for 2 to 4 weeks can still be used first line, but if not responding, then do consider taking swabs for culture and sensitivity here, as the proper identification of organisms is critical. For potential coexisting gram-negative bacteria, you can soak the feet in 1 in 80,000 potassium permanganate solution, so for example 1 permitab dissolved in 4 litres of warm water, twice a day for 10 to 15 minutes. But do warn your patients to apply Vaseline to their nails to avoid these becoming stained brown. Now, because many other conditions mimic Intertrigo, such as inverse psoriasis, seborrheic dermatitis, allergic contact dermatitis, tinea infections, and even autoimmune blistering diseases, it's always important to think broadly when the presentation doesn't fit or when the patient fails to improve with standard therapy. But fortunately for all of us, most patients do very well once the contributing factors are addressed. However, untreated Intertrigo can progress to more serious problems such as cellulitis. And so in high-risk populations, particularly those people who are obese, who have diabetes, or who have limited mobility, then deep ulcerations can form within their skin folds, and these may actually go unnoticed until the infection becomes severe. Overusing topical steroids, especially higher potency formulations, may also lead to thinning of the skin or striae. So in summary, Intertrigo is a common but highly preventable condition rooted in friction, moisture, and impaired skin integrity. And understanding the interplay between environmental factors and microbial overgrowth helps us recognize and manage it promptly. Preventive strategies such as controlling moisture, improving ventilation, and reducing friction still remain the cornerstone of care in these patients. So that's a very quick overview of Intertrigo, and I do hope you found it helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or even ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.